Dear chairs, dear colleagues, it's a great honor to present our works entitled Benefits and Harms of Conservative Pharmacological and Surgical Management Options for Women with Bladder Outlet Obstruction. This is a systematic review from the EU Guidelines Panel on non-neurogenic female LUTS. So I have no potential conflict of interest to report, just to mention that this work was conducted under the auspices of the EU Guidelines Office. So the aim of the systematic review was to evaluate the benefits and harms of therapeutic intervention for the management of bladder outlet obstruction in female patients. So we conducted a systematic review with a protocol registered on Prospero in May 2020. We followed the principle of the Prisma statement, and we searched the Mainline, Embase, and Cochrane Central database with the help of a research librarian on May 2020, and we updated the search on May 2021. We used the PICO approach, patient intervention, comparator, and outcomes. And so patients, the study population per se, was any adult female patients diagnosed with bladder outlet obstruction, which we defined a priori according to the 5 mentioned definition here, based on a consensus amidst the guidelines panel, because we found out that, as you may know, there are no consensual definition of female bladder outlet obstruction so far, and so and you will see a bit later that this was probably the main limitation of the present work. The exclusion criteria were male patients, of course, so any study including mixed population of male and female without a dedicated subgroup analysis in female patients only was excluded, as well as study with pediatric population or neurogenic populations. The intervention considered for inclusion basically were any therapeutic intervention, either conservative treatments, pharmacological treatments, or surgical intervention for female bladder outlet obstruction. So as you can see, we screened over 6,000 records and ended up including only 33 reports, using again this very standardized screening process and study search outlined in the Prisma statement. And so among these 33 studies included with over 1,000 patients total, there were only 6 randomized controlled trials, 1 prospective non-randomized comparative study, 4 retrospective comparative studies, and 22 prospective non-comparative series. Purely non-comparative retrospective series were excluded from this work, and as there were very few RCT, including heterogeneous treatment and various population, no meta-analysis or pooled analysis was possible. The risk of bias assessed through the risk of bias assessment tool from the Cochrane handbook was relatively high, as you may see. And so the main findings of the present work were that baclofen is the only treatment which demonstrated superior efficacy compared to placebo in female patients with functional bladder outlet obstruction, defined as urodynamically proven obstruction with no anatomical obstacle seen on cystoscopy or cystoretrogram. We also found out that alpha blockers and sildenafil were evaluated in placebo-controlled randomized trial and improved voiding parameters in female patients with non-anatomical bladder outlet obstruction, but we with comparable efficacy to the placebo groups in every study, so very hard to conclude that alpha blockers are indeed effective in female patients with functional bladder outlet obstruction, although we ended up recommending their use in the EU guidelines. And all these surgical treatment options, such as urethroplasty, transurethral bladder incision, mid-urethral sling revision, urethral dilation, were supported only by small sample single-arm prospective series. And of note, we did not find any eligible study for treatment such as sphincteric Botox injection or sacral neuromodulation. So, in conclusion, the evidence to support the use of conservative pharmacological and surgical treatments for either anatomical or functional bladder outlet obstruction are scarce, and the lack of standardized urodynamic definition for female BO clearly hampered our work and is a main limitation of our work and hampered probably research in the field. So maybe the ICS getting involved on such topic will be very, very helpful and will tremendously, we believe, help research in the field. And clearly well-designed RCTs are needed, but with homogeneous, well-defined population with a thorough preoperative workup, and we believe that at least urodynamic and cystoscopy should be done in every patient eligible for inclusion in these works. I thank you very much for